So thanks for being here this morning. I know some of you are from night shift, and so I'm not going to keep you too long. I know how hard it is to sit there and pay attention after a long like this thing. So, as part of our early mobility initiative, I think that it's always worth reviewing some of the problems that we encounter as we've tried to get that thing moving. And it seems like we've kind of run into problems with sedation and delirium in our ICU. I think we've already gotten better in the last year that we, as we started this scope of rounding. But I think, especially with so much turnover and sort of the entrenched culture of sedation we have, I think it's always nice to review things. And I think, what I'm reading in the literature is that we're not much different than a lot of other places as far as the way we treat our patients, the way we approach them. But I think that, again, reviewing this sort of stuff is actually helpful in the way we treat our patients. Okay, so I'm going to just talk about what we do, or especially you do in the front lines, treating patients that are critically ill in the ICU, and kind of go over briefly the ICU triad. We'll go over our most commonly used sedatives and their side effects a little bit, and then we'll talk about delirium and how we can recognize it and what we can do about it. Why are we here again? I think when I first started here, and certainly at the U, and where I did residency, there is this culture of overstation. I think that's kind of oversimplifying it, but I couldn't find the right words for it. But we really focus a lot on patients' comfort, and that's what we do when we look at that ICU triad. We assess their pain, their delirium, and their agitation all the time. And we like to see them comfortable or quiet so we can kind of get up with the rest of our work. So we hit them with these drugs that actually get them quieter and get them calmer. And it kind of also in the name of patient safety, but we found that sometimes we were kind of going overboard, and their RASS scores were way below -1. And so one of the things that we were trying to do when we got the early mobility going is we kind of assessed, well, why aren't physical therapists able to work with some of these patients? And it looked like the number one thing was that they were too delirious or too sedated by the time they got to them. So those are the things we try to do to take care of our patients. What we also see with people that are oversedated is it predisposes them to a number of things. I mean, it's well documented that people that are delirious and likely from oversedation have longer days on the vent and longer days in the ICU, but there's a number of other things that are related to oversedation, including increased edema, their increased risk of DVTs, they get more pressure ulcers, increased risk of GERD or regurg and aspiration, the ventilator-associated pneumonia, and with longer time in the hospital, increased risk of nosocomial infections. Again, the concept of the ICU triad. I have a really nice figure coming up where we look at the pain, delirium, agitation, and as sort of a triangle of symptoms that if you treat one, you actually can facilitate treatment of the other. We've all taken care of patients that are delirious because of either poorly treated or overtreated pain. They get, people come in with chronic narcotic use, and sometimes you don't get them back to their baseline mentation until you actually give them baseline narcotics. Same thing is true with people from, we often get people from the floor that also have decreased mental status because they've gotten morphine bolus after morphine bolus, and now they're obtunded and they've aspirated and they come to us. But this just introduces the concept that sometimes we tend to rely on one medication over the other, whether it's a sedative, whether it's propofol or mid-as, or whether it's a pain medication. But if you really are able to take the time and assess the patient, and it's usually done, because most of our patients can't talk to us, and you can identify exactly why they're presenting that way, how are they having pain, why are they having pain. You can actually decrease the amount of single class of drug you give to a patient, and you can sort of do a little polypharmacy, if you will, to actually kind of get them to where you want them to be. And I think that we're really good, or at least nurses are really good at assessing pain, nature of pain, and actually, coming up to me and saying, hey, I think, this is so-and-so is having, really bad chest pain, why don't we give her a little morphine? I think we can kind of raise the bar a little bit and do the same thing with delirium and agitation. And, if you've been around with me, we've sometimes gone over the differential diagnosis for people that have come in delirious. And it's pretty broad and it's complicated, but if we're able to do that, I think our management of delirium is also going to rise up to the level of how we manage pain. Yeah, just a little concept that we should only use sedation after we address their pain and mental status. Okay, so just as an aside, there are people that we appropriately sedate beyond the level of what we would want, which was a RASS of -1 to about 1. And this is just a list of them. You guys have seen this. Anybody that's got severe respiratory distress syndrome and probably in the proning bed probably needs to be sedated pretty heavily. Those of you who are on the surgical floor taking care of neurosurgical patients, we really want to protect that brain, and so we really monitor their intracranial pressure quite closely. Of course, anybody that's got refractory seizures probably gets intubated, and they're going to need like somewhat high doses or a continuous dosage of benzo. Anybody requiring paralytics absolutely should be sedated. You should not have a patient that is awake and paralyzed ever. That came up about a month ago. So, if you want to give someone good PTSD, you can do that. And then otherwise, patients that don't meet those criteria, we should actually try to have them as late as possible. I know you guys are all well versed in the RASS score. You guys are actually better at this than the doctors are, I think. You guys are doing it all the time and charting it. We just kind of hear a number and we hear whether it's above or below -1. And it's been validated in several studies and reported as logical, easy to administer and remember. Again, more for you guys than it is for us. I mean, I looked at it a number of times, but I don't think the rest of my group really kind of has it under strict memory. And yeah, there it is. Do you guys find the RASS score pretty easy to use? Mm-hmm. Okay. And the physical therapist, you guys use it as well?
Yep.
Okay. Just a review of the sedation we do, and again, this is a review for all of you. Propofol is probably our first line therapy. Onset of action is really quick, with less than a minute. Very short half-life, like 40 minutes. Really should be our first line therapy for sedation people that are going to need neurological assessments pretty regularly. One of the papers I read kind of pointed out as being more appropriate for neurosurgical patients, but I really think that's true for all of our patients. We're always assessing neurostatus. Because you guys are doing it like Q4 hours, even at baseline. Mm-hmm. Yeah, so I think that you want this drug if possible. Unfortunately, it does have adverse effects. It can cause hemodynamic instability. I mean, it's very common. We started within a few minutes, their blood pressure tanks after intubation, and instead of that, you request midads. It does have pro-arrhythmic and anti-arrhythmic effects. Nobody knows why. They suspect ion channel interactions. You have to check the serum triglycerides every 72 hours, and then you always have to monitor for severe metabolic acidosis or propofol infusion syndrome. Benzos, you guys know me pretty well by now, and you know that this is my favorite drug class. Midads is pretty common, very short acting, a little longer onset of action than propofol, and a fairly longer half-life, 2 to 6 hours. It does have excessive sedating effects, and especially in people we actually have on on sedation for days with another event. You've seen those people take days to wake up. Ativan is probably my own little. If you're mad at me, you can always page me and ask for Ativan. But the onset of action is actually pretty quick IV. Obviously, the oral formulations are going to take a little bit longer. The half-life is 14 hours. And the reason I actually point out half-life is, by a general rule of thumb, it takes, assuming a person has normal liver and kidney function, it takes about 6 half-lives for the drug to actually wash out of the system. So anytime you give these drugs, just kind of remember how long, what the elimination half-life is, and multiply it by 6. That's how long it's going to take for those effects to wear off. Figure if in a perfect world, a lot of times I think that these drugs, even though the drug's out there, they've already kind of disturbed the homeostasis, as it were. Whatever receptor that these drugs work on, they're going to be changed for a while, and we kind of, the effects are going to linger for days after, it's been washed out. I'm not totally against Ativan, by the way. It is first-line therapy for alcohol withdrawal and seizures. Be careful though, because I get requests a lot for insomnia and anxiety and hallucinations, which are not related to withdrawal delirium. Those are things that, again, I think we can be more sophisticated about learning, what symptom management is appropriate in those patients. And the last one is something we don't use a lot, but we see in our patients that come in. There are chronic benzos, Valium, half-life 20 to 70 hours. It has no role in the intensive care unit in general. Again, I'm not totally against this class of drugs, especially if people come in from the community and they're on them from the primary care doctor or their psychiatrists. They have severe anxiety and they need it for whatever. It's probably better to give to them. They've actually established a tolerance, so the chance of withdrawal is somewhat high. But people who are naive to this class of drugs we really need to think twice about giving them. Precedex. I used to hate this drug a lot. I think more because we were monitored for it a while ago before it became cheaper. And every time we ordered it, we got dinged. But now it's cheap. And now we have to think about using it more. And I certainly do. I think I use that like candy on Halloween. Onset of action, as you realize, is quick. Also, elimination is also quick. Has sedative and analgesic effects. I did not know that until I reviewed that this time. And has that been your experience? People improved pain management with Precedex infusions? You guys haven't noticed it. Pretty minor, I think, compared to true analgesics, but apparently it can have some interaction with some of those new receptors. I'll look at it too again. It could be a paper virus that goes through it. Increasing use and may become first-line sedating agent for ventilated patients. So I looked into some papers kind of comparing the drugs to each other, and the ones comparing propofol or Versed are kind of either they're ancient or they're not out there. But certainly the ones that are comparing the newer agents like Precedex to propofol and Versed are. Again, like any drug, we're always going to try to provide therapeutic effect with minimum side effects. This is the paper I was talking about. This is Precedex versus Midaz or propofol for sedation during prolonged mechanical ventilation. They had 2 random controlled trials, one with propofol versus Midaz, the other with Precedex versus propofol. They excluded any patient that was able to be extubated less than 24 hours. The main outcome really was looking for non-inferiority of dexmedetomidine compared to other agents. You guys are familiar with non-inferiority studies, right?
Not really.
Not really. Okay. It's a statistical. I don't say gymnastics, but it's a way to do a compare-controlled study and look for effects. Basically, you're looking for non-inferiority. And it also is a way to have studies that have smaller sample size. So for you to prove that Precedex is way more beneficial than mid-as or propofol, you need a study that's multi-center and has cast of thousands.
Good morning.
This one you can
As
have,
we
you can
read
demonstrate
this
non-inferiority
reading before
with
us, let us pray.
a way smaller sample
Dear
size,
Lord,
like 100
for
or
all
200.
the times in our lives when things
Statistically,
do
the math works
seem
out better,
right.
and
When we have that moment of clarity, when we feel there is hope.
it is cheaper. To run a study with thousands of subjects is really, really,
and
really
warms our
expensive.
face
So this is just a
and
cheaper way of
reminds
showing
us that life
kind of the
is
same thing.
a gift.
Secondary outcomes for these studies were ability of the patient to communicate pain and length of ICU stay. The results are pretty, I guess, interesting to me. The time to target sedation was actually similar between Precedex and both of the baseline drugs. The duration of mechanical ventilation was shorter with Precedex compared to mid-as, but compared to propofol, it was no different. The patient interaction is better compared to both traditional agents, and I think we see that in our unit. People on Precedex are able to be a little more awake and interact with you. But with hospital stay mortality were similar. However, there are more adverse effects, and again, we see that pretty commonly, hypertension, bradycardia with Precedex, especially compared to mid-as. So it's, I think it's getting there. I think the benefit is somewhat gray. Yeah, I think if we get our other post-ventilation or early rehabilitation stuff going, I think dexmedetomidine will be really, really the drug of choice, especially maybe later in intubation and ventilation days. I think from a financial analysis, I think propofol is still way, way, way cheaper. It's like pennies per day or something like that. I've dug up some other papers, also just kind of looking at the way we look at sedation in patients and what the best practice should be. This is something that came out in about 2000 from the University of Chicago. Again, and you're going to see that these ICU studies, really small numbers, 100, 200 patients at most. And that's just the nature of critical care studies, is that you're not going to get the thousands of people that have enrolled. You're not going to get a Framingham heart study of the ICU. These are going to be really, really small, and the benefits, if they're there, are going to be kind of really, really hard to appreciate. This is a randomized control study of 120 patients on mechanical ventilation receiving continuous sedation. This is basically looking at using a routine daily awakening trial versus, hey, I'm rounding on the patient this morning, why don't we wake that guy up, and I'll forget on that one for now because they're on 3 pressors. But they found that daily interruption sedation actually did decrease days of mechanical ventilation and ICU length of stay compared to when it didn't have that structure there. And that's something that we certainly do. But can we do it better? This is something that came out back in 2012. If you have a protocol in place that is there to minimize the use of sedation, like we're doing, I think us having a RASCL of -1, that is a protocol that we have in place with nurses that are trained in this sort of thing to actually minimize the amount of sedation we give. Does a daily awakening trial order improve anything? And this actually said no. I mean, the fact that you actually, it's, I think that's a good thing, really. So we can kind of get rid of this daily awakening trial business if we actually do a really good job of minimizing sedation like we're trying to do right now. Yeah, I'm kind of surprised. So I don't have to get up at 6 o'clock in the morning on night shifts and go around and remind people to turn off sedation. So anything that benefits me benefits me. Another study looking at early intensive care sedation. So a lot of the studies actually looked at long-term sedation, like people that were on the vent for more than 24 hours and on the vent for days. This is the first study that actually looked at deep sedation within the first 4 hours of initiation. So, who here has asked me after I've intubated somebody what I want to do with their sedation? And do you remember what I told you? said something to the effect of, they've had a rough day, let them sleep. I'll wake them up tomorrow. That is wrong. We should not do that. So this is a multi-center randomized cohort study looking at med-surg patients and events at least 24 hours. They assessed everything, so sedative agents, RAS score, delirium, hospital 180-day mortality. Deep sedation occurred in more than 3/4 of them within 4 hours of initiating ventilation. And then delirium occurred in half of them for at least 2 days. So adjusting for every other factor, diagnosis, age, sex, Apache 2 score, hospital type, early vasopressors, dialysis, yes or no, what do you think that they found? Early deep sedation found to be an independent predictor of time to extubation. So as soon as we sedate them for that intubation, the clock starts ticking. So we need to start lightening sedation pretty much within the first 4 hours of intubation. And that makes sense to me. I think that, intubation is a procedure. It's invasive, and we would like them to not remember it. But once that procedure's over, we can focus on comfort. We can assess their pain, as you guys are really good at, and then we can adjust the sedation as we can. We have to be mindful that sometimes the presence of the ET tube, one, uncomfortable, but two, can also be deliriogenic as well. But we need to try to lighten that sedation as soon as possible. Questions so far? Yes?
Regarding this then, just because we're not involved in, obviously, the intubation of patients, sorry, yeah. Are patients given a Versed bolus when they're intubated?
No, we use like a faster sedative,
Okay.
etomidate, which we don't use long-term for any sort of sedation.
And so that's just a bolus?
Yeah.
And then, so you're saying that the practice then should then shift to a light sedation following patients waking up from that bolus?
So whenever I put orders on the bathroom door, whenever I intubate, I put up 3 things. I put up the induction of sedation, right, which is etomidate usually. I put in the paralytic, and then the third thing I put in is the sedative that the nurse is going to want to keep the patient calm, and now that they have a tube down their throat.
And so are you saying that you would encourage a lighter sedation at that point then?
I would encourage establishing a RAS score of -1 to 1 soon after intubation.
Okay.
It's going to take a few minutes for the etomidate and the paralytic to wear off, but once they wear off, you've got to hit the ground running and assess their pain and consciousness. And I came with a couple papers that actually gave me a little hope about, what we can achieve in our unit. And this is a paper that came out of Denmark. A protocol of no sedation for prenatal patients receiving panel ventilation, a randomized trial. And when I say randomized trial, again, I talked to you about the size of ICU studies. Their patient size was, I think, 48 or 47 patients. So don't extrapolate too much from this. But their standard practice is to have no sedation. And so they compared a no sedation group with a control group of people who actually did get sedation, and they had the daily awakening trial. Their sedated patients received propofol for 2 days, and then after that they switched to midazolam. I'm not sure why. Their no sedation group was associated with more days off the ventilator and shorter ICU stays. There was no difference in accidental extubations, need for CT or MRI scans, or ventilator-associated pneumonia. I found that actually pretty surprising. However, agitated delirium was more frequent in the no sedation group. Yeah. So I think, there are obviously some challenges. I don't think, maybe having 0 sedation in the unit is maybe not realistic, but I think, I think we should not be afraid to go there.
factors.
You know, I think that, I don't know what the numbers are, and we could probably look into this, but we should probably look into the incidence of self-extubation since we've started being more aggressive about lightning sedation. I don't think it's been that bad. Or maybe it's because I've done part-time, but I haven't noticed.
No, it hasn't. We haven't seen a big increase, at least by what's reported in the ORs.
Right.
No, we did have a day. We had 2 with that.
Yeah,
That happens.
And both those guys did fine. So.
One went home at the
So
end of the
you're
day.
welcome, basically. Yeah.
So, delirium. This one's tough, and I think we see it in our patients a lot. You know, the incidence in any ICU is actually pretty darn high, and I think it's really hard to diagnose, as we'll see. So, how do we know someone's delirious? What do you guys go by? CAM ICU. Okay. Do you guys know what are the criteria? What's the CAM ICU testing?
Test like if they're aware of what day it is, where they are, test LOC, is what I'm trying to say. Agitation is also on there.
Attention.
Yeah.
Attention.
Yeah. So the final common definition, I think, for delirium is really inattention. That seems to be the most common symptom in people that are delirious. Certainly, I think otherwise delirium can be pretty variable. This presentation, you can get the hyperactive and hypoactive, and people that are nonverbal and that sort of thing. But inattention seems to be the most agreed upon symptom. A couple definitions, which I don't think is too useful for us in practice, but more academically. And DSM-4, which again is not a clinical. These are written by people who see patients that often, but it's defined as having 4 domains: disturbance of consciousness, a change in cognition. It happened pretty acutely, so you kind of eliminate people who came in with a baseline dementia or fluctuation. You often see people who are awake all of a sudden following commands. You call me to look at them, and I'm like, there's still a ton of what the hell are you wasting my time for? They're delirious. That happens to me all the time as a med student, so don't feel bad. And the NIH definition is sudden severe confusion and rapid changes in brain function that occur with physical or mental illness. Most common sign, inattention. Mechanisms, there are several postulated mechanisms, and again, I think that I do find this useful for us as care providers to think about, but also frustrating because I don't think, as you'll see, we have great solutions. There's a thinking that they saw people become delirious after getting deliriogenic drugs like benzos. They thought that the GABA receptors were actually pretty involved in it. They think the final common pathway and maybe deficiency of the acetylcholine in some of the neurojunctions. Other explanations: excess dopaminergic activity or lack of sleep in some people, and inflammation. Really, a lot of our people that become septic come in pretty altered. Demographics. Again, the literature is pretty variable. Incidence of delirium estimated is 6 to 8. Why don't you say where's your it really varies by who's defining it and what your population status is. I think our population is pretty high. I think we're a very high acuity ICU. Be aware of the risk factors: advanced age, history of dementia, prior use of sedatives. I don't think we're seeing that as much, but I think we kind of saw more from the floor here. And then increased severity of illness or people that are high risk of delirium. Once you give people a diagnosis of delirium, it's associated with increased mortality. The longer you're delirious, the less likely to make it out of the unit, or you're going to do well after the unit, and decreased long-term cognitive function. Types of delirium. Again, I'm not sure how useful it is therapeutically, but it may help us recognize people who meet the criteria. I think we see, most of the time we're seeing people that are mixed. We very rarely see people that are purely hyperactive, agitated. The ones that are due seem to be the ones that are actively withdrawing from alcohol or something else. The hypoactive delirium actually is the one I think that we tend to maybe see the most, but also miss the most. And it's really hard to decide to treat somebody when they're not actively acting out on you. The problem with that is that hypoactive delirium actually has a worse prognosis. But paradoxically, if you make it through the unit with a hypoactive delirium, you actually might do better from a mental status perspective in the long term. Identifying delirium, again, I think I don't know about you guys, but I think I probably missed quite a few. And it'll be interesting to see if, I mean, they compared ICU staff, meaning I think physicians and nurses, and then compared them to psychiatrists and geriatricians and psychology PhDs, and you know, the latter group found more cases of delirium than the former group. Go figure. CAM ICU is used in our unit. So just remember that the CAM ICU is just a, you know, as you know, it's just a binary yes or no. It's present or not. It's not as good as it's sort of showing trend over time as another system, which is the ICDSC. CAM ICU is much easier to see, obviously. But you get 1 point each for any of these symptoms, and anything above, anything with a score of 4 or more is positive for delirium. But you can actually see how you could do that over the course of a day or a course of several days and see improvement over time. I don't know that it's useful for us to bring that into our unit at this point. I think we have enough on our plate, and I'll look into it more to see if it's useful in other institutions. I think prevention is key, although by the time a lot of these people get to us, the person already on the barn. Outside the ICU, you know, in the ICU, I think these things actually are helpful, especially in people that are coming off of sedation and starting to wake up. You repeat, you tell them where they are, tell them what their name is, tell them what day it is. We do the noise reduction in the ICU. We talk to them, and early mobility. You know, there are a lot of pilot studies out there, and a lot of them are actually in surgical patients. But giving Haldol in people who are going to go under hip surgery apparently reduces severity and duration of delirium. Again, these are people that came in with fewer comorbidities than the people that we're seeing in the medical ICU. And again, I think we need to kind of look at more of these studies, but in some studies, our mobility actually can cut duration of delirium almost in half.
Attention please, Modified Trauma Team Adult, D-Wing, Emergency Department, Room 601, ETA 5 minutes. Attention please, Modified Trauma Team Adult, D-Wing, Emergency Department, Room 601, ETA 5 minutes. Attention please, Modified Trauma Team Adult, D-Wing, Emergency Department, Room 601, ETA 5 minutes.
And I do think we're starting to see that when we mark someone as being able to work with physical therapy, we do see what I think is a rapid improvement in their cognition. And you know, people I think are able to be extubated pretty quickly after initiating that. Again, surgical patients, low-dose Haldol or risperidone have potential, but again, expanding that to a generalized ICU population has not been shown. And then sedation using Prozac rather than benzos may reduce incidence of ICU delirium, but you already heard that from me, and that's kind of my bias a little bit. Just remember, these are all pilot studies. These are all studies of less than 100, and the literature is just, I think, very early in its stages so far. This is the can we get there portion of the delirium portion of the talk. This is I think within 2012, done at the Mayo Clinic in Minnesota. This is a quality initiative to reduce benzo use in a CT ICU. Again, they recognized the deleteriogenicity of benzos, and they started this quality initiative to reduce the use of the drug class. So pre-intervention, 50 out of 126 patients required benzos, and they received up to 20 milligrams per ICU day in people who required the use of the drug. This was their intervention. Basic education, so it was, had three portions to it. Physicians and providers were given instruction about benzos and asked to alter their prescribing behavior. Nursing staff were also educated about benzos and actually given other options, including Haldol. And then pharmacy also was part of this. And I'm not sure, I think they were given educational flyers, so they weren't part of the conversation, they were given flyers. But the end result was they actually increased antipsychotic use and increased benzo use. So I think we've done all three of these things to an extent. I've actually talked to my partners about it. Whether the practice has changed or not, I'm not sure. But the problem is also these order sets where you automatically get benzos, and if they're there, if they're available, and someone's agitated, you're going to reach for it. So these are the results after the QI. Is that they actually saw a huge reduction in the amount of benzo use. So in the population of people that required benzos went from 20 milligrams daily down to 6.7 milligrams daily, a reduction of about 2/3. So I just need to champ people to volunteer for benzo reduction use. Okay, again, small studies, very small study, 36 patients. Patients received quetiapine or placebo. Quetiapine seemed to resolve their delirium faster. I don't know how much of this is actually helping. We give these drugs, I think it just calms people. We don't know if the mechanism is actually being reversed. I think we're buying them time. I think we're just treating agitation in some of these cases, and we're just giving time for the brain to heal. Kind of like sepsis. A lot of these drugs are bacteriostatic, not bactericidal. Kind of buy them time for the body to get rid of the infection. There's another study comparing Haldol and Zyprexa. No significant difference between the two. And then another study between Haldol and olanzapine, also no difference. So yeah, I think we've got a lot of work to do here. I think that.
What was the population that study was using?
I'm sorry, which?
What was the population in that study again?
I don't remember.
Okay.
I'll have to
There was not withdrawal.
No, actually, some of these patients did not. Yeah, they didn't tell us.
Okay.
Yeah, they did not differentiate. So key points: we're really good at sedating patients. We can do it better. I think we are doing it better, actually. I think I've noticed a tangible difference in the relative skill that you guys have displayed. I think that it's been a part of, establishing regular rounds has been part of that, and reporting the RAS score and the CAM-ICU score to us during that time is really, really beneficial. Minimizing sedation can reduce duration of mechanical ventilation and ICU length of stay. There is no ideal agent. I really think it does depend on the stability of the patient, and you and I are going to have to kind of use our best clinical judgment to do that, and we can do it. I think that it does work. And finally, improve a recognition of delirium and identify risk factors and get people moving, and I think that is the end of my talk. Thank you.
Can we ask you questions?
Questions? Yes.
Okay. I have
it all worth it once you got to a shower and you could, instead of being like sponge bathed off in the bed, and you were able to go into a shower and feel the water go over you and have, obviously, you know, you have all these people helping you, but like to actually be able to sit into a shower and get clean, you felt human again. I left ICU, well, I actually spent 2 days over at the Heart and Lung Center here, whatever, for 2 days, 2 nights. But after that, I went home. They thought that I might have had to go to a rehab center or like a assisted living type area, but I went straight home.
Honestly, the tube wasn't that bad. It wasn't the worst thing. I mean, it was there. It was, I couldn't talk, I couldn't move. It's a big deal. I'm like, geez, I'm walking to the next room. It's, no big deal. And I remember like the first, my feet hit the floor, and I'm like, my legs, weren't there. Your legs feel like they're 1,000 pounds. It's so hard to move your body. And and this was just like a week and a half after I had come into the hospital, driven myself and, no big deal. But it was, how fast your muscles deteriorated and everything.
I remember the first time that they came in and told me that they wanted to get me up, and I think it was only a day or the next day, I think, that they came in and discussed getting up and getting out of bed with me, that I remember being awake. Well, the first time I got out of bed, it was completely shocking to me that I couldn't just get up. And that probably had to have been the strangest thing out of everything, even with the time lapse. The first time I tried to get up and feeling that I had like 0 strength left. The first time, I think I probably only made it down one room and back to my bed. And it literally took everything I had. It was very exhausting.
I think one of the things that we realized early on with Jenny was that she was going to go home and she was going to soon have to take care of her baby. So we really wanted to try and kind of, facilitate her recovery as quickly as we could and minimize any type of, strength loss or endurance loss that she might have had otherwise. So we ended up getting physical therapy on board pretty early on in her hospital course. And initially it was complicated just by the fact that she was so dysynchronous with the ventilator and was so kind of tenuous. Initially all we could do is just more passive range of motion, and then we kind of progressed into the stroke chair positions. And then eventually, like Jamie was talking about, she got up and walked. But I think the one thing that was the really kind of the big thing with us was just kind of realizing more of the long-term kind of ramifications and really to try and, minimize this muscle loss and wasting. Yeah, she didn't walk very far the first time she got up, but within a week, she was making laps around the unit. And I think as much as we wanted to push her, I think she wanted to push herself even more because she knew where she needed to be. When we were talking about getting up and walking, it's not after she's been extubated or the tube's been pulled out and she's on a nasal cannula. That we can walk patients on high amounts of oxygen. So Jenny, for example, was on probably 10 a peep and 90%, and she did just fine. And so I think it's not one of those things that you can expect everybody to say, oh crap, let's just walk everybody on this high amount of oxygen. But it's one of those things that we've kind of learned over the years, and our kind of safety barrier, feeling kind of safe walking people with this high oxygen requirements has gotten there because of patients and experiences and success stories like this, and realizing that we're not going to cause any harm.
I do remember having the tube in, and I remember that it was bothering me, and I kept trying to move it. I was trying to move it with my tongue, and I was trying to move it with my hand.
Sounds, maybe it's daunting for them to just get out of bed and take a few steps here or there, but the difference it makes is probably them, being a lifelong sufferer, or, we're actually recovering just tell the patients, you know what, this is your recovery. This, you know, everything more or less depends on how you are going to be. If you're going to just sit there and let us move you around and, you know, lift your arms and put you in a wheelchair and take you to the shower and wash you, you know, that's how you need for a really long time. If you want to be self-sufficient, then you need to make it happen. I mean, it wasn't easy, but just knowing the end goal, it was, you know, I didn't know it was going to help in my recovery. It was just, you know what, I need to walk. I can't sit in the bed. The bed is horrible. It's, you know, it gets old after a day or two.
But the most important thing I think that I would tell doctors and staff, nurses, physical therapists, all of that, is it's probably going to be a lot more work for you to actually get your patients up and out of bed and working with them versus them just being sedated and laying in bed. But I can tell you from my personal experience of laying in the bed and not being able to move and actually getting up and being able to walk and move and get around and take care of myself, not sufficiently for a while, but be able to walk on my own, to be able to feed myself, to be able to learn how to talk again, to be able to do all your daily activities that we all take for granted. You need to work with those patients to get them back to that stage. Because if you don't, you are making it, your job is not, you're not doing your job. You are hindering those patients and you are not letting them be themselves. You're not letting them be humans. You're letting them be bodies, basically. And you are just, they're just your test dummies to see how far you can push the medicine on them to make them get better. So it needs to be your responsibility to make them better. And it's going to be hard on you and hard on the patients, but in order for those patients to be humans again, to feel like they're needed and they have a purpose in life, you are going to have to be the ones to push yourself to push them. And it's going to be a lot more work. Like I said, for you to actually push your limits, to actually push them, but it's going to be better for everyone in the long run.
I'd just like to say that I think out of everything, I know that the doctor told me that with as sick as I was and everything I had went through when I was here, most patients either don't survive or they're in the ICU for at least 6 months. I was in and out in less than a month. And getting up and moving around and being mobile and them working with me to getting back to doing things on my own was what did it for me, why I got out of here so fast. I was determined that I would do whatever I had to do to go home. So they told me I had to walk, so I walked. You know, they told me I had to eat, so I ate. I would do anything. So, and I think it made all the difference. I'm back to doing things that I did before I got sick. I mean, there are things that still are strenuous, but it's 100% better. So the 6 months that I would have spent in the ICU, I'm a full-time mom and I work full-time. So getting up and moving, I think, definitely helped with me getting home and being able to live my life again.
Alright, any questions about the video? I kind of liked it. Like I said, I came from a very special unit that started doing a lot of mobility work early on. And I'll kind of talk about that in a little bit. But it was part of the day. That was part of us. Every patient, we tried to get the sedation off, we tried to walk them. And it was great to see the outcomes. As you saw, most of them went home. They went home functional, might have gone home on oxygen, might have gone home with PT, but they didn't spend weeks on the floor. They didn't go to sniffs. You know, it used to be that's what we would do, and we'll kind of talk about that. The goal of ICU is just to make them survive. But the goal of decreasing delirium, the goal of mobility is actually to let them be humans, let them get home and get back to that same functioning level they had been. Margaret Harridge is a critical care physician and researcher out of Canada from the University of Toronto. She started doing a lot of work with ARDS, and I really love this quote that she had. So there appears to be significant potential for harm arising from the current ICU culture of patient immobility and an often excessive or unnecessary use of sedation. This is a culture that began for all the right reasons, but the culture has persisted despite emerging evidence that these current practices may alone or in combination with acute illness that precipitated ICU admission have important adverse consequences that may not be remediable over time. We need to change the management of these patients. Sedation is great. We used it. We started using it for the right reasons. We're always doing everything in medicine for the patient's best outcome. We're trying to do the best, but some of the stuff that we do can cause problems with them. It can harm them in other ways besides what brought them into the hospital. There's a lot of talk now. A lot is going on about ICU. You know, Mike has been suggesting to a lot of people to listen to a podcast, so we'll kind of get a link to that put up. But this was an article in the New York Times just this year, in April, just talking about my ICU patient lived. Is that enough? That used to be our gold standard. We used to care about they survived, we were successful, we shipped them off to a SNF with a trach and a peg, but they're alive, yay. There's a lot more now that we want to talk about the outcomes of these patients. And this isn't brand new. This is 2011, the Wall Street Journal started talking about the ABCDEs, what we're trying to do to make the ICU outcomes better for patients, for their lives. So a lot of the things we're looking for is the quality of life. As providers of critical care, we must realize that survival is no longer the gold standard outcome that we focus our energy on. The things we choose to do or choose not to do have long-term effects on the lives of patients we serve. You know, I love that video. Two of the women in that video that I shared, one was pregnant, one had just had her baby, and they had stuff to do. They got life to live. Well, you didn't notice Kennelie, the blonde. She's a real little one. We coded her, I don't know how many times, 3, 4, 5 times. Wow. And her husband basically moved in. We brought baby in. It was kind of crazy while she was still kind of out of it. So she was a focus for a lot of us on the unit. We wanted to make sure she could go home and have that family. And she actually has 2 more kids, doing great. Sorry, back to this. Because we don't see those effects doesn't mean they aren't real, or does not mean they're not our responsibility. Post-ICU syndrome, it's a big deal. So it has effects all over the place. One part we talk about is families. They have to deal with it. They're coming in, we see these families that are going through grief, they have PTSD, depression. But the patient, the survivor, is affected in many ways. Mental health, cognitive, physical impairments. Delirium has a lot to do with it. They're all intertwined. Mike was talking about delirium and, you know, huge effects on anxiety, PTSD, depression, also cognitive function, memory, attention, all these things. So what we're doing now to treat our patients and keep them alive actually is affecting them much further along. There's a lot of work going on right now with the post-intensive care syndrome. There's a lot of facilities that are actually creating clinics for this. They're trying to do a lot of work with it. But I think a lot of this can be done up front. It's great to take care of after the fact, but it's better if we can avoid some of these things. Some of the physical issues that we have, that we see about ICU and weakness. You know, these are kind of anecdotal, but when I tried to hold a cup, I spilled it on my bed. I couldn't brush my own teeth. I could not comb my hair, and I wasn't able to pick up the covers and move them. Another, I could barely move. I would try to walk across the room, but I had to sit down. I was so tired. I'd rest in a chair, then on the couch somewhere else. It took me forever to get anything done. You know, people before their illness were living a normal life, were contributing to society. But their illness, everything else that's going on has affected them. And I'll kind of show a little bit more of Margaret Heritage's study. Is she got to follow them 1 year after, 5 years after. So you have long-term effects. But why? So I was fortunate enough a couple months ago to go down to Oregon and go on a mobility conference that was there. And it was great. We had one of the physicians from the University of Washington was able to present, Dr. Hogue. And she talked a lot of it about what's happening with the nerves and muscles. So when you're in a critical illness, you have nerve dysfunction, denervation, muscle atrophies, myopathies, loss of strength, loss of force. The pathogenesis, bacterial toxins cause problems. MODS, multiple organ dysfunction, has inflammation, oxidant injury, metabolic derangements, drugs, inactivity. So a lot of things are happening and affecting negatively the nerves and the muscles. When we look at the atrophy of muscles, so we're looking at time and days, what's going on, single organ failure, multi-organ failure. So this study was looking at the change in the cross-section of the rectus femoris, and just look at 10 days, the drop, you're losing 20% of your muscle. If this patient came in with multi-organ failure, and a patient with just single organ failure is losing about 7% of their muscle in that time. So just lying in bed for a week is, patients are just wasting away. Weak patients have worse outcomes. So increased duration of ventilation, you're going to have longer time on the ventilation. So 1 to 3 weeks if you have weakness. It's the most significant predictor in prolonged muscle weakness and mechanical ventilation. Longer ICU and hospital stays. More likely to be re-intubated. They're the ones that are failing their trials. Less likely to go home and hospital discharge. Going to rehabs, going to SNFs. More likely to die in the hospital. And they experience delays in rehab. It takes them longer to get their strength back, to walk, to work. Especially we're seeing a lot more of these obese patients. Every day, they're strong patients. They're carrying around a lot of weight every day. But think if they lose 20% of that mass, they can't even walk themselves compared to, you know, the little tiny grandma that doesn't need as much of her muscle mass to do it. These guys physically can't walk and have to start all over again. So it just has a lot of poor outcomes on patients and on their life. So back to Margaret Heritage, so 1 year survivors. So survivors in the acute respiratory distress syndrome have persistent functional disability 1 year after discharge from the ICU. Most patients have extrapulmonary conditions, but the muscle wasting and weakness are the most prominent. So it's not necessarily just the pneumonia or the sepsis or whatever it was that caused the initial problem with the ARDS, but that muscle wasting. They still have problems breathing due to the muscle wasting. Risk factors for the ICU acquired weakness is the clinical illness itself. What brought them here? Sepsis, SIRS, multiple organ failure. ICU medication, so there's a lot of thought, maybe risk factors. Some newer studies though are looking at neuromuscular blockades and steroids, and they're looking that the neuromuscular blockades are not significantly associated with recent ARDS, and steroids not significantly associated with neuromyopathy. So we are giving drugs, but now we're starting to see maybe that's not the biggest cause of the problem that we used to think. Other potential modifiable risk factors are blood transfusions, fluid, and duration of bed rest. So immobility, it's bad for the whole body. Dale Needham does a lot of work on immobility as well as Peter Morris. And so looking at some of their studies, the effects on muscles, we've talked about atrophy, decreases strength, loss of mitochondria, effects on metabolism, increased insulin resistance. You know, how many of our patients need insulin when they're not diabetic before they came into the hospital? Decreased protein synthesis and fatty acid metabolism, cardiovascular effects, so baroreceptor dysfunction and orthostatic intolerance, decreased contractile length, strength of the myocardium, and inflammation. So has problems on the muscular system and on neutrophil migration to the lung. This isn't new though. So this wasn't just like, oh my gosh, we just figured this out. You know, this is back in 47, the dangers of going to bed. So, just lying in bed, isn't that good for you? So there's a lot of things that affect the outcome of an ICU patient. We talked about sedation and delirium. We all kind of know about sleep and mobility have huge effects. So this is a design created by the IHI, and it just talks about kind of the 4 things that go with it. Dr. Terry Clemmer is a physician I was lucky to work with. He worked for Intermountain Healthcare, but also presented on mobility for Institute of Healthcare Improvement. The talk, you know, they created this diagram to see where everything affects. We know sedatives affect mobility. Your patient's asleep, who we're not getting them up out of bed, we're not moving them around. Ask PT. You come up, you're like ready to go, and they're on a drip, and they're out cold. What's that affect? You're like, okay, well maybe I'll try to come back later. You got a full schedule, you're working your tails off. That might not happen. We know, Mike talked about, it affects delirium. And sedatives are not real sleep. We're not getting real sleep. You may go, oh yeah, my patient was out for 8 hours last night, that's great. They're not getting the real rest that they need. Delirium, it affects sleep. You're not getting good sleep if you're delirious. And if they're delirious, we go, oh, they're crazy, let's drug them a little bit. A little Ativan's going to help them a lot, calm them down, right? And delirium, a lot of people are like, my patient's hyperactive, they're a little crazy, I don't want to try to walk them, they're a fall risk. So sleep improves delirium. Good sleep actually helps mobility because they're awake now, they're actually able to work. And real sleep, you don't need those sedatives, so you're going to have positive outcomes there. Mobility decreases delirium, helps with the good sleep. You know, if you're working night shift, one of the best things if your patient can't really sleep, if it's safe, is get them up, get them moving, and they're going to get tired. In that video you saw some of those women were talking about how exhausted they were just from walking 10 feet or to the next room. Tire your patient out physically. Then you're going to have a pretty good night when they're actually sleeping. And, of course, less needs for sedatives. Wesley Lee has done a lot of work with Vanderbilt about the ABCDEs and started talking about them. So, to recover from critical care, we want to talk about awake and breathing trials, coordinating and choice of sedation, delirium monitoring, management, early mobility, and exercise. Recently, they've increased it. And if you guys want to learn a lot about delirium, just go to the ICUdelirium.org webpage. Lots of great stuff, lots of great videos, a lot of patient interviews also that I'd love to look at. They talk about the effects that they have, what happened in the ICU. So these are the new ABCDEFs. So assess and manage for pain. So we want to talk about pain. Maybe that's their problem. They don't necessarily need sedation, but they need some pain management. Both spontaneous breathing trials and awakening trials. So turning that sedation off. Let's see how it goes. Turn the probe off. If you got to turn it back on, remember how we do a awakening trial. We're going to put it half. If they need more, yeah, up it a little bit. But try to wake them up. Choice of sedation and analgesia. We had a nice talk about Mike on that. What's the good way to do with it? Delirium monitoring and management, early mobility, and a big thing, family engagement. I'm really excited about the work we're doing here in the unit. We're talking a lot about coming up with these diaries, so we're involving families. Our rounds is helping include families and what's going on, to talk about everything. So it'll be really good. I'll just give a little background on me. So I actually was a nurse once. It was kind of cool. I liked it, bedside. I was lucky enough to start working as a brand new grad in the respiratory special care unit, which became the respiratory ICU. It started at LDS Hospital in June of '99. What happened is a lot of the staff that worked in the shock trauma ICU, the medical ICU, started talking about their patients. Specifically, there was one young man that came into the hospital. He was in ARDS. He was not a trauma. I think he just had a pneumonia and they developed an ARDS. Well, they were doing a trial at that time doing echo. Echo is kind of like ECMO, but it was bigger machines, bigger lines. It was kind of crazy. It was a 2 nurses to 1 patient type of setup. He was one of the lucky guys to get put on echo to get this pulmonary bypass. So biggest thing, we're worried about these huge lines, about bleeding, everything could happen. So they paralyzed the crap out of that patient. Sedate and paralyzed, you do not want him moving. We're trying to rest everything anyway. So success story, he survives, does well, gets out of the ICU, goes to wherever rehab. Months later, my old boss and mentor said this guy comes in a wheelchair, this young guy. Didn't recognize him, of course. We don't know what our patients actually look like because they totally different, but they're looking like in the ICU. And found out who he was, started talking, and she was like, oh gosh, that's great, you survived, you're doing well. But it was gnawing at her, why in a wheelchair? Well, all the paralytics created neuropathies. So months later, this young kid is not walking on his own, still going through all this rehab. And they're going, we did this to him. What can we do to get better outcomes? How can we not do this to someone else? You know, and the patient, he's like happy to be alive. He's like, I was teetering on death, just like the women in the video, like, wow, I'm alive, that's great. But the caregivers are going, yeah, you're alive, but we put you in a wheelchair, at least for the moment. You know, he was able to get out of it later on. So they wanted to start working on it. They wanted to see what can we do different. There were not a lot, in the 90s, there's not a lot of studies out there dealing with mobility, moving patients, waking patients up. So they created a special 8-bed unit, and they started looking at patients that came from other ICUs, the failure to weans, the ones that just couldn't get off the vent, and started working with them to try to get better outcomes for them. In 2008, it moved into a brand new hospital. They built a whole new campus, and you know, just as when it was LDS Hospital, and then when it was Intermountain Medical Center, the respiratory ICU was there. It's a Trauma 1 tertiary care teaching academic facility. So they actually got a lot of support. It's kind of crazy to get the support in the hospital. Just said, hey, here's a unit, why don't you start it, do these great things. Not going to find that a lot anymore. Can't get a lot of research going that way. So they went on to publish. They first published in 2007 about mobility, but they started the work back in '99. So my mentor and the manager I worked for, Dave Spieler, and Dr. Terry Clemmer, actually became faculty for Institute of Healthcare Improvement, IHI, and would go all over the country and talk about early mobility and the work they did. We had a conference at our hospital in 2011, and based on the ABCDEs, Wes Neely from Vanderbilt went there. I had a great opportunity. So I started as a bedside nurse in this unit, then I became the educator, then I became the manager. And I got the opportunity to kind of talk about the whole delirium and the CAM scoring with Wes Neely to all these people that came to the conference. Kind of cool. But I had to throw this out. This was from the IHI annual report, showing a picture in our unit, walking a patient with PT, CNA, and you know, I gotta put myself out there. I was a nurse, I did wear scrubs. I can wear scrubs, I gotta say. I was kind of proud of that moment, alright? So I can do it. I maybe can't chart an epic, we'll ask Christy about that stuff, but I can nurse. Okay, so this is a study this was one of the first studies published about safety of mobility in the ICU. And this was the group from the respiratory ICU at LDS Hospital. So Bailey was one of the nurse practitioners, was the lead author on it. I love this picture here. So this is one of the pictures of the unit, the old 8-bed unit before we moved to the new hospital. And what I love to show about this guy here is that he can do mobility. He's on crutches, he's walking around instead of a walker. Normally we went with a walker, but he's only got one leg. And he's doing early mobility, intubated. The RN's here, we got ART lines, everything's hooked up, feeding tube, ART lines, RT, PT, just going and getting him around. It can be done. The nurse practitioner who was in the video, the guy, had mentioned we've been doing this. The comfort level was there. You know, looking at the patient, we could go, okay, yeah, they are in PIPA 10 and at 90%. We'll walk that patient. It's not going to happen here. We're going the low-hanging fruit. We're starting with what's really safe patients to walk. But it is a safe thing. So they've had ICU. We want activity with all the patients, so we include patients that were on mechanical ventilation at least 4 days. Criteria, they had to have a neurologic response. Respond to verbal stimulus, so that's that RAS of -1. They didn't have to have a conversation, they didn't have to know everything that was going on, but they had to respond to that verbal stimulus. We started the trial with less than a PEPA-10 and less than a FiO2 of 60%, and then no orthostasis, not on pressors for these patients. So I want to make sure you guys know early mobility isn't just walking intubated patients. It's sitting at the side of the bed, sitting in a chair, and ambulating. That was our goal. The team is PTs, RTs, RNs, and a critical care tech. The outcome was to be able to ambulate 100 feet when they discharged from the ICU. So this study followed 103 patients. Kind of just a breakdown here, Apache scores of 26, multi-organ failures, their PF ratios, ICU length of stay, hospital length of stay. So we're talking 18 days in the ICU, 22 days in the hospital. So kind of long-term, you know, patients that weren't so simple to take care of. This is a list at the last day in the respiratory ICU, what activity they were getting. So only 2 patients of all of this didn't have activity the last day. Some were sitting on the bed, some were in the chair, some were ambulating less than 100 feet. Majority of those patients were walking more than 100 feet. So they surpassed the goal. So most patients, by getting that intervention early on and continuing to do it on a daily basis, were able to have this strength when they left the ICU. And if you notice, a lot of the women in that video went home. So yeah, they had oxygen needs. We took care of their needs. When they were extubated, they still had their strength. So we were able to send them home even from the ICU on oxygen with a little support, but they didn't have to like start all over. The key about this study was to talk about the feasibility and safety of it. Not necessarily looking at the outcomes, but making sure it could be done. No one had done a study, no one had published a study for it. So there were 14 adverse events out of 1,449 activities. 5 were falls to the knees without injury, 4 systolic blood pressures went below 90, 3 oxygen desaturations below 80, 1 small bowel feeding tube came out, and 1 systolic blood pressure over 200. 14 less than 1%, and none of them were big problems. You know, we get scared of the patients. We're like, what about the tube? What about this? You got a team there. You have an RT that their focus is on the ET tube. You have a physical therapist focused on the body of the patient. You have a nurse focused on those tubes and lines. So it can be done safely. It is feasible. We've done it here. So a couple years ago, we talked about this. We started working on our mobility. This guy, Nick, was great. We were able, he was in his bed, awake, on his ET tube. We found out the best way for him to communicate was his iPhone. He'd just be able to text and do that. Wouldn't that be great? Your patient can actually talk to you instead of like, try to word it, you try to play charades, it doesn't work so well. He can go, I have pain, or whatever it was, I need to go to the bathroom. Instead of you just coming in and finding out they went to the bathroom and had to clean it up later, right? So you did it here. I just want to talk about the feasibility. There wasn't big staffing changes in the respiratory ICU. Still had a 1 to 2 nurse to patient ratio. RT now, this RT ratio was we had 1 RT in for an 8-bed unit. So it really was a 1 to 8, or I'm sorry, that's RT. PT wasn't a 1 to 8. RT was just their regular assignments. So it did take time out of their day, but it was their regular assignments per bed. But we're not the only people that took a look at this. So Schweikert does a lot of research on early mobility, did a randomized controlled trial looking at physical and occupational therapy. So what they did is they started looking at doing their therapies early. So in their protocol, they started seeing their patients were about the same, randomized to it. So Apache scored 19 to 20, no big difference. But the ones that were seen by PT and OT, 1.5 days compared to 7.5 days. Out of bed within 2 days, out of bed within a week. They were standing in 3.5 days, standing in about a week. and walking in about a week, walking in about 4 days. So when it's on your mind, when it's on your radar, look at those interventions we can get in. We saw the atrophy of those 10 days, right? Muscle atrophy, look how fast we can nip that in the bud instead of letting 6 days go by. So we can save our patients a lot of torment. And this is just looking at their studies. So ventilator-free days, ICU delirium days, length of stay. So the parts that are statistically significant. Length of stay was 2 days less in the ICU. Hospital, it was about half a day, so they still went to the floor. There's some other research to look about after they go to the floor, when you get the high intensive in the ICU, but then you kind of lose some of that when you leave that, when you walk out of it. And mortality. So just some great stuff from their study when it was just all talking about getting early PT and OT. So is it safe? Morris does a lot of research on it also. So there were no adverse events in their group. 1.4% of passive and active sessions were not initiated because of either a high or low blood pressure. So very few weren't done. Less than 1% of sessions were not initiated because of too high or too low heart rate. Most frequent reason for ending a mobility session was patient fatigue occurring without a significant change in the patient's vital signs and no accidental removal of device. So, all of a sudden we're starting to show, research can show that it's safe to move ICU patients. Same type of thing, Schweikert with his follow-up, almost 400 physical events, 0 falls in the knees, 0 systolic changes, 1 oxygen desat, no changes in blood pressure over 200, no unplanned extubations. It can be done. What about the benefits? So on post-intensive care syndrome, so decreases delirium from 2 to 4 days, decreased delirium duration, 53 days versus 31 days, decreased ICU length of stay, 7 days to 4.9, and these are all just different studies, sorry, and their outcomes that they measured for early mobility. Hospital length of stay in Needham's study was 17.2 days to 14.1, so that's 3-day difference in how long they've been in the hospital. Decrease in ICU length of stay in this study was about half a day, and the hospital was almost 3 days. Decrease in mechanical ventilation, so you're a day less on the ventilator. In the ICU, you're looking about 2.5 days less in the ICU, 3 days less in the ICU. So huge impact we can have on patients, especially in the ICU. Now, you will notice a lot of times the ICU is the big difference. That might be your 3 or 4 days different, and they still spend about the same amount of time on the floor. It's a little different. One of the things you got to look at is the floor ratio doesn't change, the workload doesn't change out there. So they get the intensive therapy, the intensive work from us in the ICU during that time. Huge impact though on what these patients are going to do. So we took some tools, the system has a few tools, and we kind of took a look at them here in our ICU. And this is the mobility screening algorithm that we have. Now, we have these tools, you guys have a copy in front of you, but on our MICU webpage under resources and under ABCDE, these tools are available as well as the mobility protocol. So it's all about screening your patient. So you want to take a look. What can they do? So green is they're good to go. Yellow, let's be careful about it. Red, or we're a little concerned about doing mobility on them. So just kind of what they're able to do and have these conversations. Rounds is a great place. Is your patient good to go? Are we green with this patient? Do they have that RAS of -2 to +1? Are they cleared spinally? No neurodeficits? No ortho injuries? If they're intubated, we're looking at a PEEP less than 10 and an FiO2 less than 50%, that low-hanging fruit. And then what the mobility is. That's great, I want y'all to be aggressive, but you don't have to run your patient out and take them down to the shower day 1. Let's just see if they can sit up. And PT is gonna talk a little bit about kind of as we move on there. But look at these things, but it's also, oh no, we're yellow, we're not gonna do it. What can we do to move from yellow to green? How can we use that algorithm? So these are levels of mobility, so on the back side of that. So passive range of motion, this is that patient that's sedated, non-responsive, you know, RN, you're turning them every 2 hours. Let's do some range of motion. Let's help them out somehow. But we want to see what we can do also to move them up, right? And then first step is sitting upright, dangling, out of bed, ambulating. Any questions on that? I know I kind of did a quick run through of it. And we have, these should be conversations we're having in rounds. So when we're going there, what's our patient at? What level are they at? What's their activity plan today? Because we want to see, this just kind of talks about progressing it, which is pretty simple, but so I'll just kind of skip over those. What our next steps are. What are we going to do for our patients here in the medical ICU? How are we going to move them? How are we going to decrease sedation? How are we going to get that there? So a lot of goals we're looking at, we've been talking about we want patients off their sedation at night so that we can do an SBT in the morning. You know, it's awesome and cool to take a nice video of a patient on an ET tube walking down the hall with a group of people around them. It's so much better if they actually don't have that ET tube and you don't need that whole group of people and they only need 1 or 2 hands to help them out. So SBT is a great thing to do, so we want to get that sedation off, do the SBT. Now I'm getting new data from Mike as of this morning about what that sedation is and getting extubated, so we'll kind of take a peek at that. But our goal is, if you're working night shift and you've had them sedated, get that off. So in the morning they can be up, awake, in the chair before rounds of 9 o'clock. That's what we'd love to see. RT, they don't want to walk patients, let's be honest. That's a lot of time. They're going to work really hard at getting that patient extubated. And we actually saw that when we first did mobility a couple years ago, before a lot of you may have come to the unit. The RTs were like, oh no, we're ready. We're ready to extubate. They were just jumping on that. Awesome, even better. I like that. Also, one of our goals is we want to push to walk two patients that are eligible A. We'd love to see them walking. Those ones are low-hanging fruit. If we don't have patients that can't walk, even better. But I know we have a few of them on those vans, a few of them that need this therapy. Let's see what else. Any questions? I know I ran through them pretty quick. So next thing is we're going to do is we're just going to talk about kind of these steps of mobility. So I'm going to turn time over to PT to just talk about that. A lot of it, you know, I am concerned about you all. A lot of this is moving patients. We're not all trained on how to actually move patients. We've had a lot of injuries, right? We've had back problems. We've had pulling issues. So I'd love, as we're doing a lot of these things, as we're trying to dangle, we're trying to position the patients. I'd love to learn how to do it safely from physical therapy so we can be a great help to our patients, a great help to them, and to not hurt ourselves. Let's help patients, let's not harm ourselves, let's not harm patients, and let's have some great outcomes.
Cool. So Chrissy said she has room 650 set up, so we'll just go straight to her room and just kind of talk over a couple of things, and then we'll be done.
And you all can be guinea pigs.